Thank you, sir. Good afternoon to my esteemed guests and to the audience who are still here with us, dropping their lunch for the sake of this session. And so I'll be talking about the dropping of the lids only, which is called ptosis. By definition, it is whether one or two eyes, both the eyes are droopy. It could be congenital or acquired, we all know. And these are the ptosis workup cases where we see the vertical fissure height, margin reflex distance, crease distance, LPS and all. We all know all these things. We also know that there are so many procedures which can be used to correct ptosis, ranging from mullerectomy, Fasanella sulfate, LBS, and to the sling surgeries. These are the commoner ones, the congenital ptosis, where you need the tarsofrontal slings. This is the result. Good result. Not much of lag ophthalmos later on, but initial days, maybe a week or 2 weeks, there could be nocturnal lag ophthalmos, but that should not prohibit us from doing these surgeries. LPS is a better one to do for congenital cases, but if there is an LPS action of grade 5 millimeters or more, acquired and senile, we all know, is still one of the most common one in ages beyond 50s or 60s, like in this age, around 90 plus, and he was taken care of by both his LPS exploration and reattachment. Wonderful results, and he was comfortable thereafter. You see the eyebrows and the forehead folds which have gone off after the surgery has been done, so he was relieved of pushing pressures. This all we know. So what we are here to talk about is the variations which are not normally seen in the clinics, or not, they go unnoticed, like ptosis with hypotropia, or we call it as double elevator palsy or mono elevation defect, or ptosis with Marcus gun phenomena, when there is a jaw winking phenomena. In these type of cases, in the previous one, you should correct the squint surgery first. You should do the squint surgery first, correct the hypotropia, reassess the ptosis, and then correct the ptosis. And this, you should counsel the patient pre-operatively nicely. Most of the times, the LPS section is variable, and you should decide your surgical intervention accordingly, and counsel the patient pre-operatively that there could be some element of Marcus gun even after your surgery is done. Blepharophimosis sometimes confused with ptosis if it comes later in age, but here we have a variant of decreased horizontal fissure width along with the vertical fissure width. So we have to do a two-stage surgery sometimes to increase the horizontal fissure width, which is in the first go, and thereafter the second stage surgery to increase the vertical fissure height. So you can see from this, which is the top picture, to the lower right, that is the type of beauty you can give to the patient and to the parents are comfortable with. In this lady, what I'm trying to show is the inferior scleral show here in the ptotic eyelid. Most of the times when you correct the ptosis, the inferior scleral show automatically goes off. But I had counseled this lady earlier before the surgery was done, and you see even after the ptosis surgery, there was not much of correction of inferior scleral show. But as she was counseled well, so she didn't create any ruckus, and I did a second stage surgery for her to correct her lower lid also. So after correcting her lower lid, now she has a far better look. So you can still again compare this one. The upper lid is corrected, but the lower lid still has that lag, and which was taken care of by the second surgery. So sometimes you need to do this lower lid retraction repair. So that is again a variation of a normal ptosis case. We all know about the myogenic and the neurogenic traumatic and mechanical cases, which is again has to be taken care of in your busy OPD. Sometimes we miss on the variations in the diurnal phases, myasthenia gravis, and sometimes CPEO when the movements are also restricted. Neurogenic, third nerve palsy, of course, the history is very important, traumatic and mechanical. We'll cover one by one, and I'll rush through these slides. Myasthenia gravis could be only ocular as well as generalized myasthenia gravis. So only 15% have purely ocular myasthenia. It can be fluctuations during the day, worsening of ocular movements and the symptoms while watching television, reading, writing, driving, worsening of jaw muscle weaknesses and all. See, it looks like she's a case of ptosis, simply a case of ptosis, but no, she is not. She's a case of myasthenia gravis. Sometimes the patient may present to you with diplopia and even with squinting. So all those needs to be taken care of while assessing the patient. These all are variations which are quite commonly present in the ptotic cases. These are the few tests which you need to be getting done, like Estelle enzyme, anti-acetylcholine receptor antibodies. Tensilon test is not so commonly performed nowadays. EMGs, sometimes you may have positive response. A very normal ICE test which can be done in the clinic, or you can call it a clinic office test, which is easy and you can see response in response to the ice or the cold. These are the medicines used to treat myasthenia gravis. Alternative to this, we can do ptosis crutches. Ptosis surgery is not very much recommended, but sometimes you need to do it with under correction because if the movements are restricted. Similarly, in diplopia, because these are transient cases, by the time your medicines are acting, you can use patches, prisms to relieve the patient of diplopia, and sometimes strabismus surgeries can be done, but they have a poor outcome. Like in this multineuropathy, in a diabetic neuropathy patient, again, it's a neuropathy case. Again, a variant of ptosis, looks like a simple ptosis, but it is not. So you can use a crutch glasses till he is relieved of his condition. Till then, you can use this crutch glasses to lift his lids and to give him comfort. Later on, he gets corrected once his neuropathy is gone. Third nerve palsy, again, is very common. You have the restriction of movements along with the ptosis. You may have or may not have a dilated pupil. So in this case, again, time is the concern. You just need to counsel the patient and give a hand holding. Afterwards, patient gets corrected. You see in this case, I did nothing. Just gave him placebos, gave her placebos and methylcobalamin, and she was totally fine. Your diagnosis has to be good. But here, sometimes there are some very unique cases, like this gentleman presented with sudden onset ptosis. So you see that the inflammation in the eye is red and there is inflammation. I got the ultrasonography and the MRI is done, and we find out cysticercosis in LPS, SRLPS complex. So that was treated. Similarly, this girl, again, acute onset ptosis. It could be because of swelling, because of blepharochalasis, but yes, because of LPS, again, cysticercosis. Treated well with medicines, and see, she responded wonderfully in just 1 week. Sometimes there are congenital conditions like this, enophthalmos with ptosis, where there is restriction in the movements. So you have to reach to the ground basic reason why the ptosis is there. In this, I corrected the enophthalmos first by doing orbital surgery, and later on I did an ptosis correction. So after doing an orbital plus ptosis correction, you see some wonderful results in this. Straight away going in for ptosis correction would not have been a good result. Sometimes it is only mechanical ptosis. You lift the lid and you see there's underlying condition, some large chalazion, capillary hemangiomas and all. Treat accordingly. Don't jump into the conclusion of having ptosis. Like in this case, this lady seemed to have ptosis, chronic history, but when I lifted, you see there is a subconjunctival lesion, which was a salmon patch-like appearance, which is nothing else but non-Hodgkin's lymphoma. And for this young chap, again a conjunctival lesion, who was treated for this lesion, and he got corrected of ptosis without doing ptosis surgery, but taking care of the underlying pathology. Sometimes microcornea appears to us like ptosis, so you have to counsel the patient and treat accordingly. Thyroid orbitopathy, and sometimes lid retraction of one eye leads to ptosis of other. So treat the lid retraction and not the ptosis. I hereby extend my warm welcome and invitation to all of you to please block your dates for the midterm AIOS, which is going to be held in the city of Amritsar in your own Punjab. So we would like to have you all there, and kindly pass this message to your colleagues and friends around. Thank you very much for your patient hearing. The dates are September 26, 27, 28th. Any questions, I'll be happy to answer.
Thank you, Raman. What surgery you did for the hypertrophy in that lady? After the ptosis surgery, you had a
No, sir, it was not a hypertropia.
Yeah,
it was an inferior scleral show. So the lower lid was retracted. I did a lateral tarsus strip for that. Yes, sir.
That's all but fine.
Yes, sir.